quality indicator, a good indicator for physician productivity from a trending standpoint. To the next slide. So how do groups use it, and how do hospitals use it? You know, they're really kind of angling into the same scope when they use RVUs. They really want to use it from a productivity standpoint. So if you have a group and you've got various providers, it's a great way to measure how a physician's doing compared to his peers. But as we get into this, I'm going to kind of highlight some of the areas that can really get you in trouble. As I look at the attendees, I see one of the folks I was just meeting with earlier today, where we were meeting with a group's accountant, and he brought up, hey, let's show them RVUs. Have you shown them RVUs yet? You know, the group we were talking about has providers that provide different kinds of services within a group. It's a cardiology group. So even though everyone's dealing with the heart, there's diagnostics, there's hospital work, there's office-oriented work. And so the RVUs can swing dramatically within a group. Where if you have a primary care group where you don't have a lot of testing, it's basically focused on office, I think you can get, you don't have the wild swings, and you have a better comparative than you do when you get into some of the specialties. And we'll talk a little bit more about this as we go. It's also used as a very common compensation model. You don't see it so much in groups. But physicians who are employed by healthcare systems, they use this to drive their compensation. And I see it used in different ways. I'll see that they will either compensate a doc so many dollars per RVU that they generate, or there'll be a base salary, which is very common, usually somewhere around the 50th percentile of MGMA statistics, and then they will use the RVUs to add a productivity bonus. So if for the last year you generated 8,000 RVUs, any RVUs after 8,000 will pay you $45 per RVU. And it's a bonus or something to help push the doc to increase his productivity, see more patients, whatever the case may be. And then again, they use it also to establish a baseline productivity in the event of a hospital purchase or employment event. So hospitals will look back if they're going to bring a physician on, and they'll look at usually the last 2 years of total worked RVUs. And they want to make sure that once that doc is on a salary or a paycheck, that he doesn't then reduce his productivity. He's still hungry. He still has some kind of benchmark to hit as far as keeping him busy, and just because he's on a steady check, he doesn't drop his productivity in the office. Now, when you're using RVUs to measure productivity, there's a couple of things to take into consideration. One is your system reports. I was once brought into a hospital situation where we had a physician who's, you know, he was at one point before they hired him, and he dropped dramatically. And the first thing they turned to was, there's got to be something wrong with billing. And maybe there was. But again, as we looked into it, your RVUs are only going to generate as your CPT codes are entered correctly into the system. So again, the coding side of this is important. The fact that your RVUs in your system are updated, because annually they change, so make sure that your numbers are correct. And then make sure you're capturing everything associated with that doc. Sometimes when they generate a report, it may not capture everything for the RVU, all the RVU totals for that provider. So you really want to make sure when you're running these reports that you're comfortable with them, that they are including everything. And when I say everything, as we go a little further into this, everything gets to be things that aren't always directly associated with the doc that can skew these results. So it's really important that you understand the report and what's rolling into it for those particular providers. The other thing is MGMA, national organization, they do cost surveys. And so a lot of primary care and specialty groups participate in these cost surveys. If you haven't ever used their information, it's pretty helpful. You have to be a little careful because it can be a bit generic, such as when you're looking at maybe OB RVUs, it would be for the western part of the U.S. or the eastern part of the U.S. Are they using extenders with them? Do they do a lot of surgical procedures? And so when you compare your docs to a doc in MGMA, you got to kind of take it with a grain of salt. It's a good generic indicator to use to let you know if you're in the ballpark, but it also opens the door to a lot of questions. And so these are kind of some of the things we're going to talk about here as I give you some examples. Here's just some RVUs. I pulled at random, really had no focus on any one specialty. But just to give you an idea, if you're not familiar with RVUs, what their values look like. So for a 99212, a low-level office visit, it's 0.48 would be the RVU for it. You see a new patient visit right underneath that. That's more involved, obviously. You're going to spend more time on that history with that patient, getting to know the patient, reviewing the new meds, versus updating the meds on a regular, returning patient. And you can see, because it's a little bit more involved, you're looking at 1.42. If you're going to administer a vaccine, depending on what the vaccine is, this was unlisted, 0.17. Again, a very quick encounter, doesn't take a lot of time, so you see the reduced amount. When you look at a vaginal delivery, obviously more time involved, 28.69. C-section, more time involved, 31.8. And then just a couple cardiology RVU numbers. Cardiac cath, 8.34. Cath takes about 20-25 minutes for a doc to do. Coronary bypass surgery, 22.51. So, interesting to me, a bypass surgery takes about 3 hours versus how long a vaginal delivery might take. When you look at it, you'd think one would be higher than the other. Again, I think there's a lot that goes into deciding these things. They're constantly being updated on an annual basis. But it gives you an idea for types of services, type of time commitment a physician or maybe an RN, if they're giving an injection, is involved with. You can see here what kind of the RVUs look like for those billing codes associated with those type of procedures. And you can see how much they vary. So pretty interesting. And one thing to think about, too, docs who are really into their RVUs, they know what ones generate more RVU value. And so docs can be very competitive, and they'll study this, and they'll figure out a way to get through this to where they can maximize their RVUs. And I'll give you a couple examples here. This is one that, just to kind of give you an idea, I was talking about, we're looking at docs, and again, these are rough numbers, but I'm going to tell you about a meeting that I had a couple years back with the group. And it was a group that, cardiology group, they meet at the time every Tuesday morning. They have a guy come in and cater breakfast, make some made-to-order omelets. Back then, years ago, cardiology was very well reimbursed. Yeah, they've had some cuts now, so they don't make quite the money they do, so the days of omelets are over. But I remember this specific meeting because we were getting together to review general practice information. And we had one physician who walked in the room, and he waited till everybody was in the room, and then he comes in, and he's wearing a shirt with dollar signs all over it. He has a gold chain necklace around his neck with dollar sign hanging from it, and he swaggers into the room, and he drops a stack of reports that he ran, basically showing his RVUs compared to everybody else. And the docs are all looking at him, laughing at first, but then when we look at this report, and again, this is where you have to be really careful, and this came up in a meeting earlier today with some folks. When you put doctors' numbers side by side in front of docs, obviously docs are really competitive. Everybody likes to be the big dog, the top guy, and nobody wants to be at the bottom. And so as an administrator, I'll use data to push docs to change behaviors and accomplish things. But some places I do not go with reports, and this was one of them definitely that I would not go there, and that's kind of what we talked about earlier today in the same circumstance. This is not the kind of report you throw out in front of a group of docs who have a varying style of how they practice. So Dr. A. Dr. A's an office doc. It can be any one of the docs in this office. But for Dr. A, they're going to see the office visits, which are lower RVUs. This one generated just over 3,800 in a year RVUs. Doesn't sound like a lot. When you look at MGMA, it's right in the ballpark of where a cardiologist in the office would be. Dr. B's an interventionist. He's over in the hospital. He's doing procedures. He's going to generate higher RVUs because of what he does. And then Dr. C, and this was the guy with the dollar signs. And he's the one that said, I'm tired of carrying you guys. You need to step it up, as he threw the reports on the table. He was at 8,300 plus. But when you look at the detail, and unfortunately we didn't have time to prepare when this guy walked in and threw these reports on the table. When you look at the detail, Dr. C is doing diagnostics, so he's overseeing stress tests. He's overseeing echo. And other people are performing those studies, echo techs, nuclear techs, but they're doing it under his supervision. So the RVUs roll up underneath him. This office also has cardiac rehab in it. So those RVUs for those patients in cardiac rehab that are being charged roll to the supervising physician, which is Dr. C. So he puts it out there that he's the guy. And yet, in this scenario, he was the guy that, one, benefited from Dr. A, because Dr. A, the office guy that's seeing those new consults, that's seeing those office follow-ups, that's ordering those diagnostics, you know, Dr. C is really the beneficiary of that. I always say when you get into specialty type groups, they're like pyramids. So the bottom of the pyramid and the width of that base of that bottom of the pyramid is the office visits, the new patient consults. And that's what generates the follow-up testing, which generates the follow-up procedures. And so they generate a lot of downstream revenue. And so you can't discount Dr. A's contribution here. Even though the RVUs make it not look so important, he has a big impact on downstream revenue in this circumstance. He's the one that, you know, ultimately leads to interventions in the hospital. But it has to be a whole team look at it, and that's where this particular example went really wrong. And so, you know, one, we try and not let the docs get any reports we're not aware of. It's okay if they ask for them, but, you know, if somebody's running a report, I ask for a heads up on it beforehand so I don't get surprised. I certainly want to look at it before it's put in front of the entire group. But here's a way that you can see RVUs just twisted within a group. Now, if you're in a group that is more common in how they practice, common in what they do, such as a primary care group, a pediatric group, where you don't have a lot of deviation, I think that the RVU indicators are much more telling of how the docs compare against each other, and a really good tool for that. But even beyond that, I think RVUs are an excellent way to trend how a doc's productivity is going. You know, are they seeing more patients during the day or less patients during the day than one of their peers who is in the office in the same amount of time? So again, it's something to look at. The other thing too is, you know, a lot of offices, including primary care, use extenders. So if you've got a nurse practitioner or a PA that's in the office and they are not credentialed independently, so they are being billed under a supervising physician, you get into the same thing. You got to be careful because now that supervising physician is going to see those RVUs roll to them. You can run individual reports usually on these extenders and break it out on what their contribution was. But you still got to watch it. In a primary care setting, if you've got these extenders, you can hit this. If you're an internal medicine doc and you do stress tests in your office, that will obviously add to your RVUs. If there's echoes being done in your office, same thing. So just kind of think about everything that's contributing to your RVU values when you're drawing conclusions. and make sure that there's a direct component of what the doc actually did, and then sometimes there's an indirect component, extenders, diagnostics, whatever the case may be. Again, just to kind of recap on that. So is the scope of practice different on your docs that you're looking at? Are they using extenders? Does the physician assist? Cardiac surgery. I work with cardiac surgeons quite a bit. They are ones that like to assist each other. So, with a cardiac surgeon practice, usually, that's a 3-hour surgery. But during parts of surgery, sometimes a second surgeon comes in. They'll help take the vein out of the leg that's being used for the bypass graft. They'll assist in the chest for 20, 30 minutes while they're on their pump run and attaching those grafts. But then they exit. So that assisting surgeon could only be in there maybe 20 to 45 minutes. First, the surgeon, the primary surgeon's in there 2.5, 3 hours. What do you think the RVU difference is between those two surgeons for being in that room? It's the same. The assisting surgeon gets the same amount of RVU value as the primary surgeon. They certainly don't get paid the same. Cardiac surgery, you could be looking at $700, $800, depending on your commercial insurance, maybe $1,200 for a surgery. The assisting surgeon's going to get $150, $200. So even though the RVU value is the same, dollars collected are not going to be. So, you can't just rely on RVU values. I argued this with a hospital once, and it really set on setting up some cardiac surgeons on strictly an RVU compensation model. And I kept harping on that, collections and RVUs are two different things. You can't eat an RVU. But collections, that's real money. That's what you're after. It's something that you can measure, and it's real. It's real dollars in your bank. An RVU is nothing more than a productivity indicator. And then the last point, does a physician supervise other clinical areas? Again, if your doc's supervising an area where CPT codes are being generated from a billing event and they are rolling to that doc as the supervising physician, you need to be aware of that. All right, as I get into this, talk about a hospital hiring a physician. And your group may be happy how they are, they're independent, or I could have folks here that are from hospitals. But, it's definitely the trend that a lot of physician groups are being purchased by hospitals at a rate that has never been seen, I don't think, in the time I've been in healthcare. And a lot of factors have led to that. A lot of the reimbursement reductions, security of having that hospital check. Some docs just don't want to deal with the headaches of running a practice and have that responsibility. And a lot of the new docs coming out, they don't want to buy into a practice. The days of buy-ins have gone away. And so a lot of docs just think it's much easier to go into an employed situation. But in this case, this example, a true example, is a hospital group that was buying up local practices. So this doc was already established in the area. He was an OB doc. He paid himself $350,000 a year. He collected $450,000. Had a small office with 2 employees in there, so he didn't have a lot of overhead. His worked RVUs for the last 2 years averaged 8,500 for the year. When you just do some quick calculations, I like to look at collections versus RVU. So I'm taking it, I'm dividing the 450 by the 8,500. And you see it's $52.94. And then I look at his pay over RVUs. It's about $41 an RVU when you divide the 350 by the 850 or 8,500. So the hospital was pretty comfortable bringing this one on board. They really didn't want him to leave the market because of compensation concerns. So, they wanted to have OBs in the market and not jeopardize their OB program. So they went to MGMA, they looked up and looked at worked RVUs, 75th percentile, 5389. Okay, we're looking at 5294, we're good. We're underneath the 75th percentile. They looked at worked RVUs for the doc, 8,200 versus 85, they're good with that. They're in the ballpark. One thing just to know, when hospitals look at acquiring physicians, they usually put them right around the 50th percentile for income. But you know, if the doc's busy, and that's indicated by worked RVUs, they'll go higher. They'll usually go up to 75th percentile. They rarely go over 75th percentile, because if you do, it could look like you are paying a doc above market. You get yourself into some legal issues. And so if you go above the 75th MGMA percentile, you really have to document why. Is this doc work 6 days a week? Are you paying him call pay? There's a lot of reasons for it. But getting back to this scenario, so there's the scenario. They looked at historical information. They're comfortable with it, so no risk there. They looked at MGMA. Hey, right in the ballpark. Everything looks good there. Everything looks good to proceed. So hospital puts out their little marketing thing in the paper. We'd like to welcome Dr. A, our newly hired OB. Everybody's excited. You know, they changed the signs out in front of his office. Give him a 5-year contract, which most hospital contracts are 3 to 5 years. It's tied to productivity. It's in line with MGMA benchmarks. As I like to say, what could possibly go wrong? Well, and that's an actual quote from the doc. Thanks for the raise, suckers. His first year total RVUs, 12,000. First to 8,500 he'd done the previous 2 years. His first year compensation, 492 grand versus 350. 40% raise. He was thrilled. Now here's the kicker. His first year collections were 480 grand. First previously 450. Hospital scratching their head. First thing they said is, there must be something wrong with billing. Looked at it, the collection rate was the same. Nothing wrong with billing. No significant changes there. Doc couldn't be thrilled more. He's locked in for 4 more years. All the other OBs are banging on the door. They want a piece of this action. So what happened? Oh, hold on, let me just back. What happened was that doc assisted every OB in the area on every delivery, every GYN procedure, every chance he got, he came in and he assisted. Now, if you're a patient, hey, 2 docs are always better than 1, right? I mean, you'd want somebody else in there just in case something goes wrong. It's great to have a second pair of hands. But, again, getting back to the cardiac surgery example, this doc was able to really increase his RVUs 40% in this case to drive up his income and back the hospital right into the corner. He ate their lunch. And that, in this case, this person's contract was in such a situation where they couldn't get out of it. Sometimes these contracts have a clause in there where these RVUs will be rechecked a year later, and you know, if there's changes in reimbursement or direct changes in RVU, the contract could be renegotiated. This had no such clause. So this guy had them. And you know what? I mean, what's the hospital going to say? You can't go help another doc? Again, you know, 2 docs are better than 1. I mean, I saw the cardiac surgeons use the same argument with this hospital that they were working with. They said the same thing. If you're laying on that table and we've got your chest cracked open, would you rather have 1 cardiac surgeon in the room or 2 cardiac surgeons? Everybody's going to say, I feel better with 2. Same thing here. This guy used it. He goes, it's a quality of care issue we're talking about, not a money issue. That's what the doc kept throwing at him. It was brilliant. But, again, it's a way that this can be misused. It's a way that if you're going into these kind of situations, you want to think about it. You want to understand your RVUs very carefully for the type of practice you have and the scope of that practice. And you want to be just careful that you cannot get this thing where it gets twisted in such a way that it presents a picture that is inaccurate. So when you're looking at these kind of scenarios, you've got to be very careful if you're moving toward an RVU situation where you're comparing one doc to another, and you especially need to be very careful when you're looking at it from a compensation standpoint. So, in summary, you know, the tool is not for everyone. You know, it's a great tool for an administrator to look at and track. You have to be very careful if you're going to present this. You know, again, I was in a meeting earlier today, and we talked about presenting this to a group of docs. And you know, right away, it's like, no, let's not do that. You know, I mean, it's a very slippery slope when you go down that road and you put this kind of data in front of people. Just like I'm sure that there's times where you put production information in front of the doc, and you show total dollars collected by doc. And you can see that docs will vary, even though sometimes they have a very similar practice. But you'll see things where maybe one doc takes more Medicaid than another. And as a result, his collection rate's lower. Maybe one doc does a little bit more of a procedure, or it gets involved in diagnostics. It's the same kind of relationships that you see in collections carrying into RVUs. And so the same kind of concerns have to be there. And when I say the devil's in the detail, it really is. You need to understand it before you put this in front of the docs, because there'll be a lot of questions. If you're comparing one doc to another, nobody likes to be on the bottom, so they're going to push hard against you going, why? You better be able to explain those whys in this scenario. Again, I've seen RVUs used for good. I've seen RVUs used for evil, quite honestly. I've seen them very maliciously manipulated for somebody to make their point or to better their position from a compensation standpoint. So when you go into these kind of situations, it's good to talk with folks. Had a doc talk to me last weekend who his practice is about to be purchased. And you know, same thing, part of his compensation is going to be RVUs. And you know, I threw out a lot of these type of questions to him, and it really changed how he wanted to proceed with his contracts and things he wanted in there. And from a group standpoint, again, it's a very slippery slope. A lot of groups, if they are using RVUs, it's maybe a productivity bonus on a group that is very light in its scope of practice. So understand the different components of this, and make sure that you've got a good handle on your data. You know it's accurate. You know where these numbers are coming from and what's making those numbers up. And then I think you're in a better position to talk to the docs and you know, discuss that further with them. And last but not least, I'll open up for questions. I may not get through all the questions, but my email's on here too, so I'm happy to respond afterwards if that's the case. Let's see here. Can I answer any questions? If you just type them in, I can grab them here off the computer screen. Don't see any questions, so if nothing else, again, I'm going to leave my email where questions can be still submitted, and I'll be happy to return them for you. Looks like a lot of folks joined the conference. I really appreciate you taking your time to listen on my thoughts regarding RVUs. And again, my contact information is available here. If you've got questions, I'd be happy to talk with you or answer email. So thanks so much for joining in and spending some time talking about RVUs. I hope it was helpful. And again, if you have any questions, feel free to utilize my contact information. Thanks so much. Bye-bye.